Hello and welcome to our listeners from around the world. This is JAMA Network Open Conversations. I'm Angel Desai, Associate Editor for JAMA Network Open. Today we are speaking with Dr. Ravi Parikh and Dr. Sandhya Mudumbi about algorithm-based palliative care in patients with cancer, a pragmatic cluster randomized trial. Welcome to the both of you. To begin, can I have you both introduce yourselves?
Sure. I'm Ravi Parikh. I am a medical oncologist and an associate professor at Emory University.
I'm Sandhya Mudumbi. I'm a palliative care physician and the medical director for supportive care at Tennessee Oncology.
I want to start just by saying I thought this was a really interesting study. I'm really excited to talk to both of you about it today. I think there's recently been a lot of discussion surrounding the many applications of automated defaults embedded in EHR to try to increase participation in health-related activities. But as you know, much of this work has been conducted in academic settings. And so with that in mind, could you give us a bit of background on the concept behind this study?
So, as you mentioned, a lot of the early trials of early palliative care have been not necessarily pragmatic, but heavily controlled. And that's intentional because they're meant to establish the efficacy of using early palliative care, in a controlled population. So you want to control the dose of palliative care that's being received. You want to control the interactions. But in scaling those concepts, which are well over a decade old, in terms of the evidence basis for early palliative care into the real world community-based setting, particularly in community-based oncology, there's a lot of other considerations around workforce shortages, staffing, and also just what's going to trigger a consultation, since to my knowledge, no community oncology practice is routinely establishing early specialty palliative care at the time of diagnosis of advanced disease. And so in thinking about these effectiveness gaps, I think the time has been ripe for more of an effectiveness-based trial trying to scale this in a pragmatic setting to community oncology and embedding, as you mentioned, electronic health record-based defaults as a way to prompt these consultations instead of relying on purely clinician-driven identification of patients.
Yeah, and I can add to that a little bit. I felt very passionate about doing this in the community oncology setting because I actually came from the academic world and came on at Tennessee Oncology to lead the palliative care program. And I really struggled a lot with trying to translate a lot of the academic standards for palliative care and how things work to how things are done in the community, which is like inherently very practical and just considering real world problems, right? The other point I want to make is that, the majority of cancer patients in America are treated at community oncology practices. So when we think about a service like palliative care, it's very important to also show people that it is feasible to try to increase early palliative care access within the community oncology setting too.
I think that's a great introduction. To begin, can you give us a brief overview about what you did in this study?
Sure, yeah. So what we did was run a pragmatic cluster randomized trial, meaning that we randomized clusters of patients at the clinic level to receiving either intervention or control. And the intervention in this case was a default electronic health record-based referral to palliative care. And when I say default, I mean that a primary oncologist had the opportunity to opt out of these consultations via a simple electronic interface, versus control, which in this case consisted of the ongoing usual practice, which consisted of peer comparisons of palliative care rates at the clinician level. I think one of the interesting study design aspects of this was that patients were identified as eligible not by some sort of crude disease-based criteria or by clinician identification, but instead by an automated electronic health record-based algorithm that was adapted from National Comprehensive Cancer Network guidelines, and so represent more of a scalable identification strategy that could be used in the automated setting in routine community oncology practice where there aren't necessarily loads and loads of clinical research coordinators who are available to screen patients for this type of intervention.
What's super unique about this collaboration between the academic and community setting is that Ravi and his team didn't come to us and say, hey, this is what we need to do. They actually came to us and really engaged with us on what the problems were for us to implement early palliative care. And so for us, we noticed actually there was a lot of support for palliative care among our oncologists, but it seemed like in a busy clinic day, that it seemed to fall sort of lower on the priority of things. And there was also like kind of this cognitive burden of trying to remember every time when they saw an advanced cancer patient to try to introduce it to them. And then on the flip side, so we had the support, but it seemed like it was hard to remember to introduce it to patients and make the referrals. On the flip side, a lot of times in palliative care teams, there's often concerns about overwhelming the capacity that we do have and the staffing that we do have. Just because, when you think about like a default, like let's try to just refer everybody, that's always the first response I get when I talk to palliative care team members. And so that's really where we wanted to try to incorporate this risk stratification method to try to see, can we get to the highest risk patients and try to preserve our capacity and to meet the need for these higher risk patients in the advanced cancer population.
These are great points. Can you walk us through the primary and some of the secondary outcomes that you looked at in the course of the study?
Sure. So our primary outcome was the completion of a palliative care visit, meaning actually being seen by a specialty palliative care clinician, either via telemedicine or in person, within 12 weeks of being identified by the algorithm and enrolling in the study. Now, those palliative care visits were chosen as the outcome because the intervention was intended to reinforce an evidence-based practice. Prior palliative care studies have looked at measures like quality of life or patient mood or other symptom-based outcomes. But we already know the evidence-based that specialty palliative care improves those. Our goal was just to get that to patients. Other exploratory outcomes in the study included patient quality of life, which we assessed on a subset of patients using a particular validated quality of life measure, in addition to a scale called heard and understood, which is a measure of how heard and understood patients felt by their primary oncology team. The other exploratory marker that we studied was intensive end-of-life care, which used a validated definition that included receipt of systemic therapy in the last 14 days of life and a hospice referral less than 3 days before death.
At our community oncology practice, and I found this, I served on a national palliative care committee for our community oncology network, One Oncology, and so I'd frequently talk to practices. No one ever argued with the value of palliative care when it came to patient-reported outcomes, frankly, even end-of-life care use. So for us, it really was more meaningful to try a method that increased the receipt of early palliative care for patients. So that's where we felt it was really important for the primary outcome to be, can we actually move the needle on more people getting palliative care?
And what did you find?
So our primary outcome showed that our intervention with the automated EHR algorithm with default orders increased palliative care consultations from 8.3% in the control group to 43.9% in our intervention group. And then even within the intervention group, we had 63% of patients agreed to the palliative care consultation. So what was also unique about our intervention is that we did this default opt-out pathway where the oncologist could say if they disagreed and they can opt out of the pathway. But once that happened, once there was no opt-out and we kept moving with the default, a palliative care coordinator actually reached out to the patient and really engaged them in a dialogue about what palliative care means, and they could ask questions. And, a lot of times she would alleviate a lot of fears for people too, especially surrounding the stigma of palliative care. And so I thought this was really important to see too, is that 63% of those patients that had the default palliative care pathway, 63% of them agreed to the consultation.
So maybe I can touch a little bit on some of the exploratory outcomes, which again weren't the primary outcome of the study, but I still think provide a lot of important data for thinking about the value potentially scaling this. So probably our most relevant exploratory outcome was that we found that rates of systemic therapy within 14 days of death, which again is an evidence-based quality metric of low-value end-of-life care, were reduced from 16.1% in the control group to 6.5% in the intervention group. And, that's really important because, that translates not only to improved patient-centered care near the end of life, but also improved value of end-of-life care, since systemic therapy near the end of life is arguably one of the most commonly accepted value metrics across all of cancer care. We did not find any differences in rates of late hospice referral between the groups or rates of improved patient-reported outcomes. But it should be noted that those trended in the positive direction towards the intervention group, and that may be an issue of just power and rates of survey completion in this pragmatic setting.
I think the findings for your primary outcome are really remarkable. It's a really large difference. Pretty amazing. I wanted to just touch on one point. So I found it interesting that in your heterogeneity analyses, that the intervention appeared to have a disproportionate impact among patients with lung compared to non-colorectal GI malignancies. Any thoughts as to why this may have been the case?
Yeah, I can give a couple of thoughts there, and then Sandhya, I'm curious to get your thoughts as well. One of the interesting things about lung cancer is it's arguably one of the earliest evidence bases for early palliative care. In fact, the seminal Temel et al. Randomized trial published in the New England Journal of Medicine in 2010 was only among patients with metastatic lung cancer. And so I think there may be some more familiarity in lung cancer compared to gastrointestinal malignancies, which are a little bit more heterogeneous, in both their cancer-related components and in terms of the underlying prognoses that are inherent within them.
Yeah, I think in general, it's so interesting. When I first came onto this community oncology practice, people would over and over again quote for me the Temel article, right? So I really do think maybe it had to do with just greater uptake of the knowledge of palliative care benefits, like within lung cancer.
When you dig down into the heterogeneity results, one of the reasons why we saw a disproportionate uptake in lung cancer is because rates of palliative care in the lung group were much lower to begin with than in the non-colorectal GI setting. The baseline rates in the control group were 5.5% for lung versus 17.2%. So they just had a lot more upward to go in the lung group of reinforcing a practice that admittedly is already evidence-based, and more so in the lung cancer setting, which was established at an earlier stage compared to the non-colorectal GI setting. So that might be, another reason. It should be noted too that we found a disproportionate increase in uptake of palliative care among individuals of non-white race. And the reason for that is somewhat similar to the lung cancer example, because those individuals ended up starting off with only about a third of the rate of palliative care consultation in the control group compared to white individuals. And then, so they just had much higher to go to sort of revert to the mean. And so uncovering those discrepancies about where palliative care had been delivered in the baseline setting is sort of informative here.
Makes a lot of sense. I want to just go back very quickly to something that you said earlier related to this sort of unique partnership between an academic institution and community-based practices. And, I think that's something that's really unique about this study. And I wanted to kind of get your perspective on whether you think that this approach is potentially scalable or generalizable to other settings within sort of offering palliative care. Particularly, I think you note in the manuscript, this is maybe a great way to reach individuals in rural settings, for example, or resource-constrained settings that may not have access otherwise.
Yeah, I can speak to that a little bit. So Tennessee Oncology is unique in that we have large palliative care program here. In fact, I think the largest within community oncology that I know of. And so that part is unique. And so sometimes I do get the question, well, what do we do in places where people don't have these large palliative care teams? And so I do think this method and this intervention is replicable in other settings as well. What we actually saw was that, despite enrolling, we had a total enrollment of around 600 patients, but actually what it came down to was about 7 to 10 new referrals per week based on our risk algorithm and what was practically happening in real time, because I had to think about that, the staffing and capacity. And so I really think using a risk algorithm and this default pathway, it's a manageable volume. And so I really think this can be replicated in other settings that don't necessarily have the same capacity in terms of palliative care staff, et cetera.
If I can just comment just more broadly on the academic community oncology partnership, I'll just say that, this is the concept of collaborating with a high functioning community oncology practice like Tennessee Oncology is sort of a pipe dream for academics who are looking to scale a lot of interventions and kind of counter the criticism that this type of intervention will only work in the ivory tower. And so we have been thinking through a lot of other potential collaborations in this general space of reinforcing value-based care principles while also establishing some novel ways of delivering those. And I think, in the future, each of these different settings offer unique strengths. From the academic side, we obviously have highly structured teams. We offer the perspective of running well-controlled trials and reinforce a lot of that, as well as having staff to potentially do mixed methods assessments after the intervention is done, or do some more exploratory analyses with highly trained biostatisticians. And yet, and still, the patients that we commonly see in the academic setting are not necessarily representative of the real world. And so when it comes to tailoring interventions to make it work in the community-based setting, as well as providing a lot of robust clinical expertise and methods expertise that is particular for designing pragmatic trials, a lot of that skill set is available in the community-based setting. We don't necessarily tap into it a lot in the quote-unquote ivory tower. And so I think we need to start doing so a lot more and really emphasizing trials that may not be as highly controlled, but are more representative and more disseminatable, at least the results are, to real-life practitioners. Because, I think that after we presented some of the results of these trials at a meeting, we got much more interest than I personally have ever gotten with any academic study that I've run, which I think just speaks to the sort of staying power of studies like this.
I think that's a great thought to end on. I want to thank you both so much for speaking with me today about this incredibly important topic. I'm Dr. Angel Desai and have been speaking with Dr. Ravi Parikh and Dr. Sandhya Mudumbi about algorithm-based palliative care in patients with cancer, a pragmatic cluster randomized trial. You can find a link to the article in this episode's description. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.